it's my great honor and pleasure to invite Dr.Brij Makkar to the dais. Dear friends, there are few people who have contributed maximally in a short time and changed the scenario of diabetes in our country. And one such person, I have no motive, I launched it assured, going back to get it assured, was Brij Makkar, who is the phenomenal RSSBI president and as president of the Society of Obesity. Dear friends, who want to take a person who was excelled in obesity research, obesity therapy, it is Brij Makkar. And I must tell you that his tenacity of purpose to take the obesity treatment in our country is great. He has been in the various parts of the globe, in the Cleveland Clinic, Mayo Clinic. He was also in various parts of the United States. He organizes a very advanced program with the Cleveland Clinic and now with EASD, and he is the author of the program. Very, very popular program. Beyond that, his contribution to the the physician health program of RSDI, under his leadership, the RSDA has made very rapid strides. Dear friends, it's my great pleasure and honor to present this gentleman to you to speak on a subject which I call two words: most important and most contemporary. You cannot refute it, am I correct, sir? Most important, most contemporary. Now, treatment of diabetes today is over glucose centric, it is obesity centric. And today, if you pick up one as the driver of NCD, it is obesity. And NCD will discuss it little later in this room. So, the driver of the cardiometabolic, the driver of the entire NCD is obesity. And to speak on this topic, and importantly, there are new drugs which are coming for the obesity treatment. To do this topic justice and take it to your listeners, I present you, dear friends, Dr. Brij.
Thank you, sir. Thank you for those very kind and almost embarrassing words. I don't deserve all that appreciation. Good morning, everyone. At the outset, I would like to thank Team JPEF, especially Jyoti, who's like younger brother, for this great opportunity. And also, one more opportunity to visit this city of Trivandrum. So I am going to speak on the future therapies for obesity management, and I will be able to give you hopefully a bird's eye view of what is happening and what is in the pipeline. We all know that obesity is now coming up. It is gaining noise, and it is getting noticed. The biggest problem with obesity is that it is all around us and we don't notice it, or basically we refuse to notice it as a problem because we have not been able to do much about management of obesity. So I don't have any financial disclosure. We all know obesity management involves lifestyle interventions, behavioral therapy, and if it is not working for most of the patients, it doesn't work, so we need pharmacotherapy. And most of the time in the recent, if you look at the last decade, we didn't have much to manage in terms of pharmacotherapy, so large number of patients would require bariatric surgery. But in last decade, there are a number of developments which have changed the whole scenario of obesity management. The bariatric surgery, which used to be the mainstay of therapy for people with significant obesity, now seems to be changing, and we seem to have more and more potent drugs, and which are going to replace bariatric surgery as the choice, and bariatric surgery possibly is on the way out. So we all know that 5 to 10% of weight loss can lead to significant reduction in the risk of diabetes, improves blood pressure, improves cardiovascular risk, improves sleep apnea, and so on. But we were always talking of 5 to 10% weight loss because most of the drugs that we had were able to give us only 5 to 10% weight loss. We didn't have very potent drugs which could replace or give a weight loss parallel to the bariatric surgery, which was going to about 15 to 30%. Then we have started seeing now weight loss going more than 15%, and we know higher the weight loss, higher is the benefit. More than 15% weight loss can lead to remission of diabetes, reduce cardiovascular disease, reduce CV deaths, and improve heart failure also. And this we are seeing now And this is becoming more of a realistic target because we have now drugs which are giving you weight loss going to 15 to 20%, and we already have semaglutide and tirzepatide available overseas for management of obesity. Now, if you look at the landscape of obesity management, initially we had lifestyle interventions which would give you a weight loss of about 3 to 5%, perhaps 8%. Then we had gastric banding giving weight loss of 15%. Then we had gastric sleeve going to 25%, bypass surgery going to about 33% weight loss. So segment that we were able to cover with drugs was only about 10 to 12% weight loss. So between lifestyle intervention and maybe gastric banding. But now things have changed, and with these new drugs, we are basically able to fill this gap which was there between the pharmacotherapy and the bariatric surgery. So we are touching the whole stream of bariatric surgery. And what has changed? The change has happened because of the so-called GLP-1 receptor agonist and company. I call it company because most of the molecules that are in development are revolving around the GLP-1 chain. Now this whole thing happened, this whole evolution of therapies happened because bariatric surgery showed us one thing, that it led to significant increase in the postprandial level of multiple enteropancreatic hormones, and possibly, if we focus on these enteropancreatic hormones, they would be effective in management of obesity, and that happened to be the case. And we started looking at all these drugs either alone or in combination with GLP-1 receptor agonists with the aim to enhance or complement the effect of GLP-1 receptor agonists in management of obesity. So we are going to see a lot of smart molecules which have multiple receptor agonist recognition, and these recognitions also are variable. Some of the molecules will have balanced effect. Some molecules are being developed with bias for one particular receptor as compared to the other receptor. And most of these molecules are revolving around the GIP, glucagon, amylin, peptide YY, GIP-1 GIP antagonist. So interesting thing is you will see GIP agonist also, GIP antagonist also for obesity management. And there are some trials which are looking at potential of other enteropancreatic hormones in combination with multiple molecules for management of obesity and cardiometabolic disease. Now, if you look at the GLP-1, we all know GLP-1 leads to increase in insulin secretion from beta cells and suppresses glucagon secretion, and thereby leads to reduction in glucose. But we also knew from liraglutide and GLP-1 studies that it has central action in brain, by which it suppresses appetite and slows gastric emptying and leads to reduction in the weight. Now, GLP receptors are present in brain, and GLP-1 receptor agonists act in the arcuate nucleus on the GLP-1 receptors, thereby stimulate the POMC CART pathway, leading to increased stimulation of melanocortin 4 receptor and thereby leading to decrease in appetite. This is the simplified mechanism of suppression of appetite by GLP-1 receptors. Now, because of this, liraglutide was the first GLP-1RA tested for management of obesity in the scale studies. But scale studies also did not show very effective weight loss, and most of the time we were able to achieve weight loss of about 6 to 7% across board with these scale studies. Then we have semaglutide. Now, semaglutide is much more potent than liraglutide. If you look at semaglutide, it gives you energy intake reduction of what? 16%. Liraglutide. Compared to this, semaglutide gives you energy intake reduction of about 35%. And it acts both in hypothalamus and high brain. And SUSTAIN was the semaglutide development program for people with type 2 diabetes. Now, in this program, the semaglutide studies showed that we were able to achieve A1C reduction going to the 1.5 or 1.7% range across board in different studies, whether it was monotherapy or combination or in comparison with other molecules. Interesting thing was there was significant almost 5%, 5.5% weight loss across board again in people with diabetes. In people with diabetes, usually you get lesser weight loss as compared to only people with only obesity and no diabetes. And there are reasons for that. So once they saw that there is significant weight loss, this became another interesting molecule to study. And then we had data from the oral semaglutide studies, which were the pioneer trials, again showing that we were able to achieve significant A1C reduction going to 1.5%, plus we were able to achieve more than 5% weight loss on more than 50% of the patients, which was again significant. And this led to development of semaglutide higher dosage for management of obesity. And this was called the STEP trials, semaglutide treatment evaluation for people with obesity. 4 STEP trials were there, which already have been published. And STEP 2 was in people with obesity and type 2 diabetes. STEP 1, 3 and 4 were in people with obesity. Interesting thing was, at the end of 1 year, there was 17% reduction in weight. The STEP program led, yes, you can see there. So about 17% reduction in weight was seen in semaglutide 2.4 milligrams given once weekly, added to standard of care as compared to placebo. And this led to their approval for management of obesity. Interesting thing was, almost 90% achieved more than 5% weight loss, 70% achieved more than 10%, almost 50% achieved more than 15% weight loss, and a quarter achieved more than 20% weight loss. And this was very significant. In addition, there was significant A1C reduction, and people who lost more than 10% weight, they lost A1C they reduced A1C by 2.2%. Now the starting A1C in this population was about 8%, 8.3%. Now if you are coming down from 8.3% by 2.2%, you are already in diabetes remission. So it led to significant remission of diabetes also in people who were treated with semaglutide. In addition, it showed some pleiotropic benefits, and these side effects were as expected with GLP-1 receptor agonists, majorly GI side effects, which were mostly mild and settled with time. And this led to approval of semaglutide in June 21 for management of obesity. It is approved in India but still not available in India. Then we started seeing data from tirzepatide, which is a dual GIP GLP-1 receptor agonist. It's a co-pegylated molecule which is developed on the GIP backbone, multifunction peptide, and this acts on both GIP and GLP-1 receptor. Now benefits of GLP-1 effect are that in addition to the effects that you are seeing with GLP-1, you will see the blue marked effects with GIP. That means there is additional weight reduction in food intake. There is decrease in nausea. GLP-1 receptor stimulation leads to increased nausea. This is leading to decreased nausea, decreased body weight, increased energy expenditure, increased lipogenesis in subcutaneous tissue, and decreased inflammation in subcutaneous tissue. So there are all positive benefits which were complementary to GLP-1. And the initial studies with tirzepatide showed that at higher dose of 15 milligrams, you were able to achieve A1C reduction going in the range of 2.4%, starting at A1C of about 8%. Again, you are pushing most of the patients back into the normal A1C range. In addition, interesting thing was there was about 11% weight loss, which was again statistically significant. Tirzepatide was initially studied in the SURPASS program, which was the tirzepatide evaluation for management of type 2 diabetes. Again, this molecule showed significant 2.3% reduction in A1C in people with diabetes. And the starting A1C was 8.3. So almost significant, more than 50% people achieving A1C of this 6%. In addition, there was significant 11%, 12% weight reduction, which was again very, very significant. And this was further followed by the SURMOUNT studies, which is the weight management with tirzepatide. SURMOUNT was the development of tirzepatide for weight management. SURMOUNT 1 was the first study to look at tirzepatide once weekly for treatment of obesity. Again showed not only there was significant reduction in weight, almost 90% people achieved weight loss of more than 5%, 80% achieved more than 10%, 70% achieved more than 15%, more than 50% achieved more than 20% weight loss with the half dose, and almost a third achieved 25% weight loss, which was very, very significant. Further data came from Surmount 3, again showing very, very similar effect. This study involved initial weight reduction with intensive lifestyle intervention, very low calorie diets for 8 weeks, and then the people were initiated on tirzepatide, followed up for 1 year. Again, it showed very significant benefit, and this got approval for management of obesity in 2023 November. Then we have data coming from the amylin analogs, which is cagrilintide, and initial studies with cagrilintide showed that it can lead to significant weight reduction going in the range of 10 and 11%. And the interesting thing is there is combination data from cagrilintide and semaglutide called CagriSema, which showed weight reduction going in the range of again 18% or so. And it is still in phase 3. Then this was the data presented from triple agonist last year at the ADA, so-called retatrutide. And this is a triple agonist, GIP, GLP-1 and glucagon. 3 receptors it is stimulating. So these are all smart molecules where one molecule has combination capability to stimulate multiple receptors. This was studied to assess the efficacy, tolerability and safety of retatrutide in multiple doses in people with obesity. And doses titrated looked at were 1 milligram to 12 milligram. So it was a very robust phase 3 trial, phase 2 trial. Interesting thing, at 24 weeks only with the higher dose we saw weight reduction going to 18%. And by 48 weeks we had A1C reduction touching 25%. And important thing was the average weight reduction was going in the range of 25 kilos, which was again very significant. All the patients achieved more than 5% weight reduction. 90% achieved more than 10 kilos, 10% weight reduction. 80% achieved more than 15%. 90%, almost 70% achieved more than 20% weight loss. 50% achieved more than 25% weight loss, and a third, 1/4 achieved more than 30% weight loss. This is what can be achieved with bariatric surgery. So you are almost close to bariatric surgery. Now question comes whether these high doses are safe. And now we have data from SELECT, which was the cardiovascular safety trial with semaglutide 2.4 milligrams in people with obesity, showing significant 20% reduction in 3-point MACE, 19% reduction in death from any cause, 18% reduction in the death endpoint of cardiovascular heart failure and death. Then we have recently got data from FLOW trial, which looked at the semaglutide on chronic kidney disease in people with diabetes, and again showed there is significant reduction which is going in the range of 24% for the first major kidney endpoint. There is 20% reduction in the first kidney specific component. There is significant reduction in the rate of decline of EGFR in people who were treated with semaglutide. There is significant 29% reduction in death from cardiovascular causes. There is significant reduction from death from any cause. So long-term data from these molecules is also promising. Now most of the therapies that you are going to see are revolving around GIP, GLP-1, alpha cell, beta cell and N cell. GLP-1 focuses on reducing appetite but it increases nausea. GIP receptor stimulation reduces appetite and decreases nausea. Amylin agonists, they lead to decreased appetite, decreased food intake. Glucagon receptor stimulation leads to decreased appetite, decreased food intake and increases nausea. PYY decreases appetite but increases nausea. So most of the molecules are being developed actually around the GLP-1 backbone. GLP-1 GIP combination, GLP-1, GIP, glucagon combination, glucagon, GIP, GLP. So multiple combinations we are going to see. And these are the list of drugs that are in various phases of trial. We have multiple drugs in phase 3. Survodutide is already advancing very well. Cagrilintide is also advancing very well. And we have orforglipron, which is the oral GLP-1 agonist. It's very likely to be there, in next 2-3 years. Then we have multiple molecules in phase 2, phase 1 trials. The interesting thing is, most of these molecules are showing very promising weight loss, going in the range of 10 to 20% or 25% at the higher doses. Not only that, the portion of people achieving weight loss of more than 10% is in the range of 50 to 90%, which is becoming very promising. And there is a significant number of people who are achieving weight loss going beyond 15%. Significant reduction in A1C in people with diabetes. Now, one challenge is whenever you are losing weight, there is likelihood of muscle mass loss, sarcopenia. So we are having a bimagrumab, which is a monoclonal antibody which is being tested in studies. This has, in addition to fat loss, this leads to increase in skeletal muscle mass. So this molecule is being studied in combination with semaglutide. Then there are other factors which are interesting, like GDF15, which is a molecule which is shown to be related to weight loss in people with tumor. It is seen in multiple cell types, but these are molecules in initial phases of studies. So with that, I come to end of my presentation, and I would like to invite you for the ACCD meeting that we are having next month on 24th, 5th of August in Delhi. And of course, block your dates for the mega RSSDI in Delhi on 14 to 17 December. I think all of you must have got the intimation by now. Block your dates, be there. This is the venue to visit in Delhi, and this is the conference to look forward to every year in the field of diabetes. Thank you.
Dr. Brij, thank you very much for a very detailed, informative, clinical and practical presentation. So I think we have two questions and two inquiries. First, we can ask you, Brij, that we recently heard that for prescribing these drugs, one did not have, they're so powerful and so effective, one did not have a what we used to call visceral metabolic conversation, or one can prescribe lifestyle, but one did not wait for a long time.
So didn't get it properly.
I mean, the Iron Sharma, who was here last month, he said that for prescribing these anti-obesity drugs, we do not wait for the lifestyle to be prescribed and then to become not very effective. You agree with me?
So important thing is the perception for anti-obesity drugs is that you take the drug, you will lose weight and then you stop it. Now, first thing is obesity is a disease. We have to understand obesity is a disease. It is not just because you eat more or you walk less or you are lazy and you are gaining weight. There is a lot of genetic component, there is a lot of environmental component, there is differential expression of genes and genetic influences on various components of obesity. So it's a dysmetabolic state. Like diabetes is a dysmetabolic state of glucose metabolism, it is a dysmetabolic state of energy metabolism. And to reset this, we need to treat it. We don't have a cure for obesity. We don't have a cure for diabetes. We don't have a cure for hypertension. We don't have a cure for obesity. You start anti-diabetic agents, control glucose. Can you stop the drugs? Answer is no. You treat patient with hypertension. You bring down blood pressure. Can you stop the drugs? Answer is no. Same is with obesity. You first initiate the drugs. You bring them to a certain level of control, and then you have to maintain it. And maintenance is the most important, area to work on. There is no drug which will take you to zero weight. If every drug is taking down the weight, bringing down weight, and it continues, you will end up at zero. You will not get blood pressure of zero with any number of drugs. So that's how.
I think any chronic disease, you cannot stop the treatment. It has to be taken for a very, very long time, maybe for eternity. The questions from the audience, one question we can take.
So as of now, we do not have data. But even in US, the big challenge is the cost of these medications. And I was at the International Congress of Obesity recently, 2 weeks back. What these people are doing is, after the initial weight loss, they are switching them, the people where, there is also insurance. So if you get into BMI less than 30, your insurance doesn't cover your treatment now. So if you are more than 30, you still get semaglutide. But you lose weight, you come to less than 30, semaglutide is stopped. This is a big challenge. So then they are switching to combinations like Viburan, pure naltrexone, or liraglutide. But we are still waiting for data on that.
Thank you, Brij. Thank you very much. Big round of applause for this. Thank you.
Thank you so much, Chef and Speaker, for the wonderful session. Without any ado, we are moving to the next session, that is Bridging the Gaps in PPG, Controlled with Insulin. To chair the session, I would like to invite Dr. Suresh Purohit, Director